Good afternoon, everyone. We will be getting started shortly. We're just going to wait a couple more minutes to allow people who are still joining. So we'll be with you shortly. Even though it's a small group, I think we'll get started because I want to make sure that there's as much time as possible for the presenters and for questions. So I'm sure we'll have some others join us, but we will get started. Um, Welcome to the clinical conversation. My name is Amy Rosenstein, and I'm the administrative director for MCPAP and the other MCPAP related programs. Welcome to the MCPAP Clinical Conversation, which takes place the fourth Tuesday each month. Next month, our topic is early psychosis, and you'll be getting some more information about that soon. Today, we are going to be providing an overview of CBHI and CBHC services. Um, a little bit of housekeeping on this screen. You will see the code for claiming CME HOZZUK, I'm sorry, X. This session is being recorded and it will be available on the MCPAP website at www.mcpap.com. A copy of the PowerPoint slides will be on the website under the Tools and Resources page under PowerPoint presentations. So we have two presenters today, and they will stop for questions at different points. But if you can hold your questions till the breaks, that'll be great. And if you have questions, the easiest thing is if you want to enter it right into the chat function, then we will be sure to address them during the question and answer breaks. You will receive a short survey after the presentation, and we would appreciate it if you could provide feedback. It's really helpful to us as we plan future presentations. So today's presenters are Jonelle Sullivan. She is the statewide youth network manager at MBHP. She's been in this role for the past 10 years and helps oversee the statewide network of providers who offer Children's Behavioral Health Initiative, or CBHI, services. Janelle has more than 19 years of experience working with kids and their families. She's worked in a variety of environments, including residential treatment centers, foster care agencies, community service agencies, and in managed care. And she is passionate about ensuring that all children across the state have access to quality services. The second person you'll hear from today is Kate Hildreth Fortin. She serves as the CBHC statewide clinical provider liaison with MBHP and Carillon Behavioral Health. And in that role, she leverages her extensive experience in enhance provider relations and ensure quality of care. Since 2019, Kate has worked at MBHP managing provider quality with a focus on emergency services and mobile crisis intervention programs, and most recently, the Community Behavioral Health Centers, or the CBHCs. Prior to 2019, Kate dedicated 19 years as a clinician, as supervisor, and director of a crisis program in the Southern Pioneer Valley in Massachusetts, bringing a wealth of knowledge and expertise to the managed care domain. So we're really pleased to have both Janelle and Kate with us today. And with that, I am going to turn it over to Janelle.
Great. Thank you, Amy. I'm just going to share my screen. Okay, so today I'm just going to provide an overview of the Children's Behavioral Health Initiative. As Amy said, the slides will be sent out and posted after. You may notice due to time, I might skip some slides or not cover every item on each slide, but you will have access to the full slide deck after today. Okay, so the Children's Behavioral Health Initiative. So what is CBHI? I think a lot of people here, people will say, oh, that kid has CBHI, that child needs CBHI, I should call CBHI, but people don't always understand sort of what the Children's Behavioral Health Initiative is. So this came about, there was a class action lawsuit filed in 2001 on behalf of youth with serious emotional disturbances. We were found to be out of compliance. And so as part of the remedy to this, the state created at the time 5 new services that were made available to children with mass health. And these 5 services fall under the umbrella of Children's Behavioral Health Initiative. So who can receive CBHI? So CBHI services are for youth age 0 to 20. They must have Mass Health Common Health or Mass Health Standard. There is one exception, Mass Health Family Assist. They may be eligible for in-home therapy, but in order to confirm this, you have to call Mass Health to check what type of Mass Health Family Assist they have. So you'd have to either call or help the family call and ask them to confirm if they have in-home therapy as a covered benefit under their Mass Health Family Assist. Recently, the state had worked with DOI, and so now there's many commercial insurances in Massachusetts that offer, they're called, you might hear them referred to as BECA or BACA services. So if a youth has a commercial plan, so say they have Blue Cross primary and then they have Mass Health secondary, you'd first have to find out if that youth has access to BECA services through Blue Cross. And then if they do not, then they could access the CBHI services through Mass Health. So you have to start with the commercial insurer to see sort of what eligibility the youth has with them before you can determine if they can access Mass Health. CBHI providers also know how to do this and can be helpful in helping families and providers contact the commercial insurances, ask the correct questions to make sure that they confirm eligibility. And then for each service, there is a separate medical necessity criteria. So a youth it's not an all or nothing. So they're not eligible for CBHI or ineligible. They might be eligible for some services under the CBHI umbrella, and then they might not be eligible for others. So when CBHI started, it was built with, it was called a hub service delivery system. So as you can see here, a youth has a mental health diagnosis and identified behavioral health needs. The next step would be that the youth's family decides whether behavioral health services may be beneficial. Obviously, providers, natural supports, other people involved in the family are going to possibly be helping assist as needed in that determination. Then the family or the provider or others could make a referral. So the outpatient therapy was around prior to CBHI, but it's included in this slide because it's also considered a hub, which I'll talk more about in another slide. In-home therapy, so IHT, that's one of the CBHI services. Intensive care coordination, which is called ICC, was a hub. And this one on the bottom, family-based intensive treatment or FIT, this is new. So this just became a service October 1st. And again, I'm going to talk more about it. So this was recently added. There's also services, in-home behavioral services. So family or provider can make a referral to this service. A youth does not need to have any other services involved to access in-home behavioral service, but in-home behavioral service is not considered a hub. So that's why it is not on this slide in the green. And then there's youth mobile crisis intervention, which is always available. And again, a youth does not have to be involved in any other services to be able to access youth mobile crisis intervention. So what does it mean to be a hub? So it basically means that this is the provider that's responsible for coordinating the care of the youth with multiple service providers involved in their treatment. They help the family make referrals and linkages to services and other community-based supports. They help with crisis and safety planning with the family, including disseminating the crisis or safety plan with other, whether it's providers that are involved in the youth's care, it might be community members, anyone that's working with the youth or family that would need to know what the crisis or safety plan is. That hub is sort of responsible for sharing that information with them. And a hub service is the only service that can make a referral for hub-dependent services. So currently there are 2 hub-dependent services. We have therapeutic mentoring, which also goes by TM, and then family support and training, which is FS&T. Family support and training is provided by Family Partner. So many times you'll hear that service referred to as Family Partner, but the actual name of the service is Family Support and Training. So I'm going to skip over the outpatient slides just for time. And I'm going to focus on the CBHI services. So I'm going to start with in-home therapy. So in-home therapy is for a youth who's in need of urgent and intensive help with emotional and behavioral challenges that cannot be addressed through outpatient therapy alone. They may have tried outpatient therapy, but treatment did not resolve the identified issues. They demonstrate poor functioning at home or in the community, and that could place them at risk for either an inpatient psychiatric facility or other out-of-home placement. This could include dangerous behavior that puts themselves or others at risk. And I apologize, I'm just having trouble advancing this slide. Okay, so what does in-home therapy offer? In-home therapy is intensive family therapy to address the youth's treatment goals and to improve family functioning. It's important to note, I think sometimes people think in-home therapy just means that a clinician meets with the youth alone, multiple times or for a long session, but it's really family therapy. And that family might look different session to session based on the need. So that could be a session with the whole family. That could be a session just with the parents, maybe the youth and one parent, the youth with a sibling. So any sort of construct of that family, but it is not it's not intensive individual therapy. It's just important to know that it really is family therapy and the family must be willing to participate. There's a flexibility and time frame and intensity of the clinical interventions. IHT teams work 7 days a week, 365 days a year. They work in any natural environment where a youth might be. That could be home, school, community, after school program. They also provide care coordination. So they do the care coordination piece with other service providers as well as natural support. So again, natural support might be extended family, neighbors, church, Boys and Girls Club, anything like that that the family's involved with that could be a support to them. The IHT team will work with them. IHT is a teamed service. So there are 2 people. There's a master's level mental health practitioner, and then there's a bachelor's or associate's level paraprofessional who has experience working with youth and families, and they assist in implementing the treatment goals. So here's just a quick example of a youth that might need in-home therapy. So Alexa calls the helpline asking about services for her son. Brian is 8 years old. He has been in therapy in the past for anxiety and depression, but currently he does not have any services. The school frequently calls Alexa because he's in the nurse's office crying and they aren't able to settle him. Brian's mother shares that she also has problems with her older son who struggles with behavior related to his autism diagnosis. And Brian has an older sister who was recently given a diagnosis of bipolar. Alexa reports that she recently separated from Brian's father. She describes the household as chaotic with constant arguing and no one obeying her rules. So this is a family that clearly has a lot going on. There's a lot of different family dynamics. There's individual members who have unique needs as well as its impact on the whole family. So this might be a youth, right? This might be someone that you want to talk to the mother about possibly accessing in-home therapy because they could come in, they could help, they could work with the whole family, they could address some of these issues. So next I'm going to go to intensive care coordination, which is ICC. So for ICC, this is for a youth who has a serious emotional disturbance, and then you can see the definition down below. They either have multiple existing or they need multiple service providers involved in their care. And there's a need for coordination of services involved in their treatment. So again, a youth has to meet all of them because there are some families that they have multiple providers involved and the family is, coordinating it. The team is working together. So that youth might not need intensive care coordination just because they have multiple service providers. There really needs to be that need for the coordination and need to pull the team together as well. So ICC offers its care planning and coordination according to the wraparound process, which is family-driven, a team-based process for planning and implementing individualized services and supports. Care planning team meetings include service providers and natural supports involved in the youth's care. They create a plan geared towards meeting the unique and holistic needs of the youth and the families with complex needs. And teams often include a family partner who works to improve the capacity of the caregiver through coaching and linking to supports and community resources. It's important to note that family partners all have lived experience having cared for a child with special needs and navigated child serving systems. So they are really a person who has that life experience that they can share with the caregivers. ICC is also, as stated above, teamed. So there's a care coordinator. So that care coordinator might be a master's level or they could be a bachelor's level staff. And they have experience working with youth and families and navigating the child or family serving systems. So here's a quick example of a youth that ICC might be an appropriate referral for. A teacher calls the helpline to learn about resources they can share with the parents of one of their students, Bianca. Bianca's mother reports that she's had significant difficulty with her over the past year. Bianca's failing in school, has experienced worsening feelings of depression, has few friends, and ran away from home twice. She's on an IEP at school. She sees a therapist for her depression and has a caseworker from the Department of Children and Families, but her behavior and symptoms have not improved. Bianca's mother states she's overwhelmed due to the number of appointments that Bianca has, and she could not remember everyone's role. So again, this youth has multiple providers involved. She has a special education system with the IEP. She has DCF. She has a therapist. But even with those supports in place, she is still struggling. So this might be a youth that would benefit from having an intensive care coordinator that could come in, pull the whole team together, help identify sort of what the goals are for this youth and family, make sure everyone is working sort of on the same page and towards that, and help teach Bianca's mom skills so that she might in the future be able to sort of coordinate Bianca's care, feel more comfortable understanding people's roles, the amount of appointments that her daughter has. So then I'm just going to briefly touch on hub dependent services because these are ones you as a PCP would not be able to make a referral, but it is important for you to know about the services because you might want to talk to if a youth has, an outpatient therapist or an in-home therapist or an ICC, you might want to share with them that your thoughts about the youth or the caregiver being able to benefit. So the hub dependent services are TM or FS&T. So here's just a little chart that kind of talks to you about sort of what the services are that they provide and who provides them. So TM, a typical youth, they have difficulty participating in activities due to a skill deficit in areas of age-appropriate behaviors, problem solving, interpersonal skills, communications, or conflict resolution. TM, it's a clinically driven one-to-one support or coaching in skill deficit areas. TMs are an individual with a high school diploma or above that has experience. And again, they're called therapeutic mentors. And then family support and training, FS&T. This is a youth's clinical condition warrants parent or caregiver peer support in resolving the youth's emotional or behavioral needs. This is a one-to-one peer education support, coaching, and guidance to the parent. They follow a do for, do with, cheer on motto and manner. And the family partner may share their own lived experience with intention with the family to tell them about sort of their experience and how they accessed and sort of worked through the different child service systems that are out there. This is provided by a caregiver of the youth with special needs who also has a high set or above, and they're called a family partner. So in-home behavioral services, currently in-home behavioral services is not a hub service and it's not hub dependent. That is changing in 2026. So the state will be making in-home behavioral services a hub, which means that if a youth only has in-home behavioral, they can now access a TM or a family partner. So again, that is a change that is coming next year in 2026. But currently, a youth who might need in-home behavioral services, it's a youth who requires a highly specialized behavior management plan across settings in order to diminish, extinguish, or improve severe and persistent behaviors. They've tried less intensive behavioral interventions that have not been successful in reducing or eliminating the problem behaviors or increasing or maintaining desirable behaviors. They have a demonstrated clinical condition, level of functioning, and intensity of need that requires the establishment of specific structure and positive behavioral supports to be applied consistently across home and school settings. And I do just want to make note, I think some people, although there's the requirement to have tried less intensive behavioral interventions, that does not necessarily mean they have to have tried a service. That could be an intervention that the parent has tried on their own, a caregiver, maybe it's something that the school has tried. There is no need to have had like a different level of care first. You can access in-home behavioral even if the youth has no sort of history of receiving formal mental health services. So what does in-home behavioral services offer? They complete a functional behavior assessment and a behavior support plan that is completed by a behavior management therapist. There's coaching of the caregivers and the team on how to respond to a target behavior. So in-home behavioral will work not only with the caregivers, but if, say, a youth also has IHT, they could help educate that team on how to respond and how to follow the behavior plan. They could work if the youth is in an after-school program. So it's not just the caregivers. They will help and work with anyone that's involved with that youth. There's data collection to track and measure the effectiveness of the intervention. And there I added the note that in January, they will become a hub service. In-home behavioral services are provided by a master's level or above behaviorist, and then an associate's level or behavior management monitor. So here's a quick example for in-home behavioral. Sam's a 9-year-old boy who lives at home with his parents and older sister. He's been working with an outpatient therapist for 6 months, but hasn't made progress. his mom reports that he's unable to sit through a full family therapy session because he gets upset when he thinks people are talking about him. He'll get up, he'll leave the room, he starts kicking the wall in the hallway. His mom reports it can take up to 30 minutes to calm him down, and by then the session is over. So mom feels that the family sessions are actually making things worse. She reports that he doesn't really do this at school. It seems to be, he seems to be able to follow directions and not have these issues at school. She says she knows they have some sort of plan that they use with him, but she hasn't seen it, and she's asked Sam about it, but he's really unable to describe sort of what it is or what's different at school. Um, so here's an example, right? This youth, this might be a case that in-home behavioral could work with the family, help create a behavior support plan to sort of target some of these behaviors, could also work with that therapist about how to react, right, if he's having these issues during family therapy sessions. It also sounds like perhaps there's something at school that's working. So the in-home behavioral could coordinate with the school to find out, does he have a plan? What does it look like? Could this plan be something that's replicated at home or in the community? Okay, so that was sort of the CBHI system as it's existed since 2009. And then in this month, October 1st, there were some changes that the state made. So the first change is there has been a reprocurement for the CSA network. So the new CSA network now has 36 CSAs. So 34 are geographic. And what that means is that depending on where a youth lives, there is a provider that's been assigned to cover that city or town. These areas mirror the CBHC catchment areas. And then there's two statewide specialty CSAs. So Walden is a statewide specialty for the deaf and hard of hearing. And then Gandara is a statewide specialty for the Latino population. So that means Walden and Gandara could serve a kid regardless of sort of where they live. And then up until October 2025, the services that had been provided by a CSA were ICC and FS&T, but they now offer this new service, family-based intensive treatment, which is FIT. And with the creation of FIT, there had been a small program called Intensive Hospital Diversion that had been being provided by 5 providers across the state. So that service has been phased out now that we have FIT. So here's just a little bit of information about FIT. It's a team-based service that provides high-touch, intense, time-limited stabilization intended for youth with high acuity needs. So to meet the eligibility, the youth has either had a crisis evaluation by a mobile crisis intervention team or an emergency department team who determines the youth is at risk of needing 24-hour level of care, or they are discharging from either a YCCS, a CBAT, a partial hospitalization, an inpatient admission, or it could be that they're currently receiving IHT, but even with that service, they're still at risk of needing a 24-hour level of care. So they offer intensive in-home therapy so it's intensive in-home therapy. So it's family therapy, it's care coordination, and there's also family support and training, which is provided by a family partner. They're expected to work directly with the youth and family 3 to 5 times per week. They provide intensive services on an average of 4 to 6 months. Youth and FIT are not eligible to receive concurrent either in-home therapy, family support and training, or intensive care coordination. So if a youth has FIT, then they cannot have those other services at the same time. They may be eligible to receive TM though. And also they may be eligible to receive in-home behavioral and ABA. It really is just a matter of talking to the family to see if they would be able to engage in both those services at the same time due to all those services are being very intense and sort of time commitment. So that might be too much for a family, but they could receive in-home behavioral or ABA with FIT. FIT is a team, so there's a master's level clinician, a bachelor's level paraprofessional, family partner, and then they all have access to in-home behavioral consultant. So if you are working with a youth or family and you feel like one of those CBHI services might make sense for them, you would go to MABA. That's the best way to find out the most up-to-date information. Our providers are required to update their availability at least once a week. So you would go to MABA, you'd select the youth and family section and find openings. And so then there's a drop down. So you'd put in the service that you're looking for, and then you'd either enter the zip code where the youth resides or their city or town. Different services have different search criteria. And then this will pull up all the providers within a 30-mile radius. So these are the providers that would be able to serve that youth, and you'll see what their availability is. There's also a comment section where many will use to highlight any expertise they have or specialty or maybe language. So then once you see what's available, you would discuss with the family so that they can make an educated decision about which provider they might like to work with. And then all the information, once you select the provider, they'll have the information listed about how to make a referral to that individual provider. And then I've attached at the end just for people to have, this is the new CSA network. So it's broken out by region. So I have slides that go over every region and it tells you the cities and towns and then the providers selected. You will notice as an example here, Boston D, there were 3 different CSAs selected. So that means all 3 of these CSAs could serve kids who live in any of these cities and towns. Other times you'll see, as an example, like Boston E, there's only one. So a youth that lives in Hingham, if they wanted ICC, family partner, or FIT, the provider that could do those services would be Bay State Community Services. If that youth lived in Brighton, that family could choose to work with either the Home for Little Wanderers, Justice Resource Institute, or Children's Services of Roxbury. And then we have at the end, we have the 2 statewide specialties. So again, to access services from Walden, someone in the family must be deaf or hard of hearing. And then for Gandara, it's their specialty is working with the Latino population. So again, you would access those, you would reach out to them and they would help determine whether or not the family met the requirements for their specialty services. If they do not, then they would help link you back to the geographic CSA that's assigned to that area. And also just wanted to say, the CSAs are a great resource for anybody, but especially sort of PCPs. I know sometimes it's hard to try to determine like which service a youth might need. They might need multiple. That's another thing, for a youth might have any combination of the CBHI services. And sometimes it's hard to tease out, like, is this a IHT referral or is this an in-home behavioral referral? So you could always call, an IHT provider to talk about that, but you can also call the CSAs. They're sort of a great resource in the community. They should be reaching out and connecting with their local sort of like PCPs, introducing themselves, inviting you to their system of care meetings so that you can meet the other providers. But they're a great resource to sort of talk through about like, this is what's going on. I'm not sure what services this youth might benefit from. Like, could you help me figure it out? And so that is a role that they play within the community. So I will stop sharing, and then if there are any questions I can answer before Kate goes.
It looks like there was one question in the chat,
Oh.
Janelle. For a patient without Mass Health, how do they get in-home therapy?
So if the youth has a commercial insurance, you'd have to call that commercial insurer to see if they have access. So they might have a service similar to in-home therapy through the BACA. So that's how they could access it. There's also, there is a way to apply. Sometimes a youth's family might have a commercial insurance, but that youth might meet eligibility. So it might be that that family needs to apply for Mass Health secondary just for that identified youth. That then could possibly open up their access to additional services. but the CBHI services that I just went over are only funded through Mass Health. So you'd need to have Mass Health Common Health or Mass Health Standard to be able to access them.
Any other questions, or should I jump in for the sake of time?
Yeah, I think it's all you, Kate.
Now, while waiting for Kate, there was one more question in the chat.
Okay. So yeah, I would suggest if you're working with a family that has private insurance, the insurance company should be able to tell you who is in their network, who's contracted. So it might be, unfortunately, if there are wait lists at their preferred agency, there might be that there are other agencies that commercial plan is connected to. I also would encourage you to use sort of the other resources. Maybe it's a call into the behavioral health helpline, which I think once Kate's, back with us, she'll be able to talk a little bit about. They might be able to help with some linkages. But the commercial insurer should be able to provide a list of who is contracted in that youth or families area.
I don't know what happened, but I lost everybody, I guess.
Well, you're back. Welcome.
I'm back. I was talking to myself for a good minute there. All right, I have to stop. This isn't gonna let me share. I guess I jinxed it because before I could share. Can you see the screen? Because I'm not.
Yes.
I don't know. You can?
Yeah, we see the
Okay.
community. Yeah.
Community else. Okay. I'm gonna just try to share from here because it's not letting me do the usual way. So sorry, everyone. I'm going to talk about community behavioral health centers and behavioral health urgent care. The community behavioral health centers came online in January of 2023 as part of the larger behavioral health roadmap. And across the Commonwealth, there's 27 locations. So essentially every city and town is assigned a CBHC. People can certainly choose to go outside of their, assigned catchment area. They just have to be able to get to that location. The services won't be delivered on any type of mobile basis. So CBHCs are one of the key physical locations in the community where someone can receive a triage and really assessment of both their mental health and substance use needs, followed by an array of urgent, routine, as well as crisis service options, which includes peer support, care coordination, and then also referrals to any other specialty needed services. I always use the example if someone comes in, they may be seen because something urgent is going on. But if they determine the need is really like the family wants something like ABA services, the CBHC would then refer them on to that. So a lot of people get confused and they think CBHC is a service. The CBHC itself is like a location, and they are required to provide a set of services that we're going to go through. So every CBHC has to provide both adult and youth, what we call core, outpatient, sometimes they're referred to as clinic services. These are available in really enhanced hours in your traditional outpatient. So they have to be available Monday through Friday, 8 a.m. to 8 p.m., and then Saturday and Sunday from 9 to 5. Again, those are available to folks of all ages. Each CBHC also must provide, and in the same location, so co-located with the outpatient, they provide adult and youth mobile crisis intervention. Many of you probably know that, mobile crisis intervention, formerly known as ESP or emergency service programs, did exist prior to CBHC, but they are really enhanced in this model. And again, they're co-located with the outpatient services. And then the third service is the adult and youth community crisis stabilization. The adult community crisis stabilization is available at almost all of the CBHCs. There are some exceptions where people partner and use other community crisis stabilizations. And then the youth community crisis stabilization, which is available for both latency age youth, which is like ages 5 to 12, and adolescents, which is 13 to 18 years, might go to youth, might go to adult, depending like if they're still in school and stuff. But those are available in more of a regional model. We have about 5 up and running right now. So not in every region, but the service is very similar to the community-based acute treatment, or CBAT. So really between the two of them, it's pretty well available across the Commonwealth. So we'll kind of dive into sort of each of the services to give you a better understanding. But the CBHC, the core outpatient, provides all the services you see here on the left. So again, they have urgent, they have same day access to get someone in, to provide an intake, a brief screening, an assessment. They're able to do ambulatory withdrawal management. They can do psychopharmacology for both mental health medications, as well as the medications you see on the right here for MAT. They are all required to provide individual therapy through evidence-based practices. So they're using, motivational interviewing or cognitive behavioral therapy, those type of therapies. They also all provide groups. It says group therapy here, but they also have a lot of groups that may not be clinical in nature. So they really do their groups based on the need that they're seeing in their community, or with those folks that are being seen at their CBHC. So you might have groups led by nurses or peers, or again, clinical in nature. So each of them usually has like a schedule of what they're offering at the time, and they change up accordingly. Care coordination is a really big piece of the core outpatient. This model was really designed to see people with, higher needs, complex needs, people who, may be the type that will end up needing to use crisis services or have in the past. So that care coordination, working with other providers, is a really key component to making sure everyone's on the same page. They're all working with the same knowledge. So, whether it's primary care, schools, clinics, they should really be collaborating with those people. They are also set up to do medical screenings. So they have nurses, LPNs, other type of staff who can do medical screenings. Obviously, there's some medical pieces that are done during like the psychiatry appointment. If someone comes in with some medical complaints, they might be able to see them. Again, the whole goal is trying to avoid emergency room visits for people that come in for behavioral health. So we'll talk about medical screenings a little bit more in the MCI piece. They have peer and paraprofessional services. So whether it's recovery coaches or certified peer specialists, they can work with people and really specialized in bringing their lived experience to the work. And then they are required to have access to and distribute Narcan. So that's sort of the core outpatient in a shell. People can come in and have one urgent appointment and choose to go somewhere else, or they can come in and have an urgent appointment and then stay with the CBHC for more ongoing care, obviously with a goal of it always being like, goal-oriented, shorter term, and not having someone in treatment for years and years. We want to keep that front door open. So we want to move people through the system as best we can, whenever we can. The mobile crisis is a 24/7 service. This is available to everyone, regardless of age or insurance. And mobile crisis really provides assessment, intervention, and stabilization to anyone experiencing a behavioral health crisis. Typically, MCI's goal is to respond within an hour. They will often respond through a team response with both a clinician who will do all the clinical components, including a risk assessment, as well as a peer staff. So they might have a peer specialist, a recovery coach, and a family partner. And the service can happen really anywhere in the community. It can happen at the physical CBHC location, it could happen at a home, a school, Dunkin' Donuts on the corner, or if the person prefers, it can happen via telehealth. You know, obviously we want someone to be age appropriate, clinically appropriate for that. CBHCs can also accept individuals directly from local law enforcement. So, you know, if police are responding to a 911 call, or they're just out in the community and they have concerns about someone, they can drop them off. There are some barriers to that. You know, some police don't do transport, or they can't transport outside of their city or town. So those are all things that we're having constant discussions with the CBHCs, and they work with the law enforcement to try to really increase this happening, again, to avoid people being dropped off at the ED for non-medical related services. The adult mobile crisis is a 3-day service, and the youth is a 7-day service. So this really allows for them to do that initial intervention, but then also to continue their work with some short-term, you know, crisis counseling, crisis planning, safety planning, and making referrals and those direct connections to other community services and supports. You might see some of that work being done by a clinician, but that's also another way, like the peer supports get involved. CBHCs have capacity really to refer through mobile crisis to all sorts of level of cares, right? So everything from your locked inpatient to your more voluntary community crisis stabilizations to outpatient. And when there's a need for that, you know, maybe it's detox, maybe it's inpatient, you know, sometimes there might be some medical concerns, or just some basic medical screening that needs to be done. And previously, people would often land in an ED for that. Even again, when there wasn't anything acute medically going on, it just became this sort of desire for units to say, like, oh, have them medically cleared, then we'll take them. In this model, they can have that done at the CBHC, you know, given that it's not anything like super acute, like, you know, they don't need an MRI or something that wouldn't be done there. So they have to operate obviously within their licensure, but they can provide that medical screening and then do direct admissions. So we continue to work with inpatient psych facilities on taking people directly from the community into their units. And we've had some success with that. Again, that's another thing that we consistently work on with our providers. And I do have some data in this deck that will speak to that. The last service is the adult and youth community crisis stabilization. It's a voluntary 24-hour level of care for people who, you know, are in some type of behavioral health crisis, and they need just more stabilization and support than can be provided in the community at that time. So it's seen as a diversion from your locked inpatient units. You know, I'm a strong proponent to advocate for people to stay in their communities where treatment can happen. We know people recover best in the community. So we always want to use this option whenever we can. CCSs have, you know, individual and group crisis treatment options. They have psychiatry, they have nursing, they have, again, they have peer support. So really they can do, you know, most of the things that an inpatient unit can do. So these referrals typically, well, they will always come either through MCI. So MCI will see somebody and make this direct connection and referral. If someone does land in an emergency room, maybe there's something medical, they've taken an overdose, something happened where, you know, 911 got called and there couldn't be a diversion. ED staff can refer to this, and then inpatient units can also refer as a step down. So if someone goes inpatient and maybe after a few days they've stabilized, but they're not quite ready to go home, they could use this as a nice, you know, step down in between to get them more stabilized to go home. There is no set length of stay for CCS, just like there isn't for inpatient. It's all based on medical necessity. And really, when mobile crisis is assessing someone, they're always going to, you know, weigh the options, right? So you might have people with very similar clinical presentations, and one of them goes inpatient and one of them doesn't. So one of the things that mobile crisis always is doing is looking at iatrogenic risk, right? What is the risk? What is the likely harm of taking someone out of their environment? And sometimes putting someone in a hospital may have more risk than not. And so those are the things that they're always looking to do. Again, mobile crisis is insurance blind. The outpatient core services, all of Mass Health is eligible for those. There are some commercial insurances that pay for it. For everybody else who's uninsured or has a commercial that doesn't pay for it, they can provide up to 3 visits. So it's a nice bridge if someone's on a wait list somewhere, if someone just really needs to get in for a few, targeted, outpatient services until they can either apply for Mass Health or maybe reinstate Mass Health. So, it's not the best, but it's something. And then CCS, the same thing. It's pretty much available to most insurances. The best way to find your CBHC providers, including mobile crisis or even CCS, is to use MABA, which Janelle had talked about. I will show a screenshot too of what that search looks like when I go through behavioral health urgent care. I'm not going to get too much into this slide. I'm just watching time, but it kind of just shows all the different options that happen through all of the different components. So the outpatient, mobile crisis, and CCS. It just kind of shows that, all the same day or next day availability for people needing treatment. So you'll have that in your slide deck. This is also a map that sort of outlines where the CBHCs are located, as well as 2 different links where you can find the information. A little bit of data. I won't go through it, all of it, but the first 3 points are claims-based data. So there is a lag. This is from July of 2025. So I'm sure the numbers even through that period are higher based on, the timeliness of claims, but it shows that CBHCs have provided over 1.4 million outpatient clinic visits, over 66,000 crisis evaluations, and over 11.7 thousand admissions to CCS. The police transports, we had over 700 occur in 2024. And in total, we had over 1.3 thousand. So it really shows how much just from 2023 to 2024 we increased. And then we're averaging about 18 direct admissions per month for the CBHCs, referring directly to inpatient psych. So again, those last 2 are things we're very much continuing to work on. CCS as well, like we're seeing that there's capacity for CCS. We really want to divert as many people from inpatient as we can when it's, safe enough to do so. But really CCSs can do really nice treatment in the community. So just to kind of wrap up the CBHC side, really we want CBHCs to be, an open access, a place where people can get treatment, and really seeing it as no wrong door. The goal of all of it is to reduce use of 911 and ED visits for behavioral health, to serve as a front door for those with behavioral health needs, and to provide coordinated and integrated outpatient care to those with complex behavioral health needs. There's no wrong way to access CBHCs. I know today we didn't go over the behavioral health helpline, but that is an excellent resource that's available 24/7 by calling, texting, or chatting. And they can help folks figure out what might be the next best step. And if that's mobile crisis, they will do a warm transfer with this person on the phone. If it's an urgent outpatient, they actually have an online system where they can send referrals straight to the CBHCs. If people know they want to access a CBHC, they know they need crisis, whatever it may be, they can just call or walk in. And the CBHC's job is really to work with folks to determine, what's the need and what treatment is best to connect someone to. So that is CBHC in a nutshell. And I'll just spend a couple minutes on behavioral health urgent care, as it was also enhanced through the behavioral health roadmap. Behavioral health urgent care is more of your traditional outpatient, your therapy and psychiatry. This is for Mass Health members, both youth and adults, who need to get into treatment more quickly. So there are about 80 behavioral health urgent care sites across the Commonwealth. I think by maybe like around 40. We just had like a change in this system, so I don't have the numbers down pat. I think there's 40 providers maybe with 80 sites. Some of them also have community behavioral health centers, but they cannot be co-located. So if someone has CBHC and behavioral health urgent care, they have to be at separate addresses. So this is just another way to enhance timely access for treatment for people. The behavioral health urgent cares all have to have some evening and some weekend availability, but it's not standard hours like CBHC. It's not set up as like a walk-in open access. So you would call, and what they can do is provide the same or next day appointments for diagnostic evals. Any of their existing folks, if they have an urgent need, they can get them in, for a sooner appointment than, if they're not scheduled for another week or two and they have an urgent need, they can get them in. And then they can also provide the urgent psychopharm, including the medication for addiction treatment or for psychiatric meds within 72 hours of the initial diagnostic. So if someone comes in, they have that diagnostic eval and they find, yeah, that's what, they really need to have a psychopharm eval, they will schedule that within 72 hours. And then all other treatment options are available within 14 days. I don't know on the behavioral health urgent care side, but I do know on the CBHC side, a lot of times folks are calling, whether it's through the helpline or directly, and they're getting offered like a same or next day appointment. And they're really like, oh, no, like, I thought there might be a wait list. So, I want to go a couple weeks out. Like I want time to prepare. So again, working with the person on what will be best for them. MAVA is definitely the best way for behavioral health urgent care to identify a provider because, like I said, the hours of operation aren't standard. Like they have to be open 8 hours per month on Saturdays, but which Saturdays they're open are going to vary provider by provider. Some folks prefer behavioral health urgent care over a CBHC because there might be a location closer to them. Something that they're just able to get to, hours at work. They might say, I don't want groups. I don't need peer support. I don't have a lot of complex needs. I just want a therapist, or I want a therapist and a psychiatrist. So those are some of the sort of different reasons someone might choose behavioral health urgent care over CBHC. So when you go into MAVA, on the mental health service page, you select the service. This is the same as Janelle had explained for CBHI. So instead of behavioral health urgent care, her said CBHI. You put in the person's age, where they're located, again, either by zip code or city town. And you can actually change the miles you want to look. So if you need someone within 30 miles, 10 miles, whatever. And then you can choose for this one. This isn't on the other like CBHI or CBHC, but for behavioral health urgent care, you can actually narrow it down by days and hours and then search and get your criteria. So one of the great parts of all of this is that if you have or someone you're working with has any problems accessing treatment or not getting the treatment I'm explaining that they provide, we have this behavioral health roadmap feedback portal, which they can use to put in feedback. So we monitor this during business hours. So it's typically either myself or my supervisor that will outreach if something comes through. We'll typically, have a conversation, get more information, and then we will do direct follow-up with providers, with the consent of the person who had the concern. If you want to give us good feedback, we always love to hear the good too, but this is specifically for the behavioral health helpline, the community behavioral health centers, and behavioral health urgent cares. So please, this is how we know if the services are working, which, we want to know. I still consider us in like the infant, toddlerish stages. So we want any feedback we can get. And then my email will be on here. So if you have any presentation needs, if you want a statewide presentation, if you work within a specific community and you want one of the CBHCs to present, we can connect you with that as well. So I know I didn't leave a lot of time, but I tried to get through everything. Any questions on CBHC or behavioral health urgent care?
Just opening it up. Any questions at all for Kate or for Janelle that you thought of? Oh, it looks like there's a question there.
Oh. Yeah, the slides will go out. Yeah.
Yeah, we will certainly send a copy of the slides. And if you think of any other questions after Janelle and Kate's emails are on their decks, and we always want to hear from you if you have any questions or, like Kate said, any training needs or anything like that. So first of all, Janelle and Kate, thank you both very much for presenting today, and thank you to everyone who joined, and we really appreciate that. If you have any questions at all, you can also email mcpap@carillon.com. Again, please remember to do the short survey after you sign off, and then also that this recording will be available on the MCPAP website. So thank you, everybody, and have a good rest of your day.
Thanks.
Thanks, everyone.
Take care.